Okay, so here's your narration for Chapter 47, Menopause and Andropause Drugs. Look over your vocabulary, make sure that you understand what these terms mean and how they apply to the concepts that we're getting ready to cover. So in this section, we're going to repeat some of the things that we discussed in 45 and then add some additional information. We will be looking at female hormones again and some different issues as far as those are concerned, and they relate to menopause. Remember that those are the estrogens and the progestins. We're going to look at how antispasmodics help with bladder issues, urinary control issues. We're going to study benign prostatic hyperplasia, or BPH, what that is, and the medications used to treat that and related to that dysfunction. So we'll look at the alpha adrenergic blockers or alpha blockers. We're going to look at the androgen hormone inhibitors, AHIs, impotence agents as well. They do not treat BPH, but BPH does cause impotence in some cases. And we're going to look at some hormonal cancer agents and how we use hormones to treat cancer a little bit more in depth than we talked about before. Okay, so menopause is a little bit different for different people as far as severity goes, as far as their perception of it and what it means to them as a person. Menopause is caused by or brought on, the process begins when we see that estrogen and the progesterone levels begin to drop. So that is the functional reason that menopause occurs. Now we make a diagnosis of completion of menopause, or say that the woman is in menopause, after a report of a full year with no menstruation. So that is important to know the differences between that. What is menopause, what is causing it, the hormone level change, and then when is a definitive diagnosis made, and that's after 12 months. So if they, go 3 months, have a period, then it starts over again. They go 6 months, have a period, it starts over again. But when they go a full 12-month cycle without, they are truly in or have completed menopause. For men, the change isn't quite so overt because they're not having a monthly sign to remind them whether or not they are within andropause, but there still are hormonal and urinary changes that occur with age in men as well. Reproductive and urinary changes associated with aging are closely related, so one kind of affects the other, if you will. Roles of estrogen within the body, we talked about this a little bit before, but it's good to know, and this is a good visual image of kind of the things to look at. What does estrogen do for us? Well, it has cholesterol protective effects. It helps move calcium and phosphorus into the bone, so bone strengthening. It kind of has an anti-aging effect to our skin, prepares the uterus monthly for pregnancy, causes and controls ovary maturation, releasing an egg, breast development and growth, that kind of thing. So if you think about what begins with menopause, think about why that brings on a set of other issues, especially as it relates to postmenopausal osteoporosis and those types of things. We no longer have that estrogen level that's maintaining that bone strength and density. So, cholesterol levels might become out of balance or begin to rise. Obviously, we no longer have a shedding of the uterine lining, which, hey, who doesn't miss that? But then the other things we have to be concerned about as well, because they can cause some serious issues. Levels of estrogen also maintains vaginal health. So postmenopausal women or women that are experiencing perimenopause might complain of vaginal dryness and things like that. So with age, vaginal walls become thinner, shorter, lose some elasticity. The vagina produces less lubrication. So it, again, could cause that dryness issue. The pH changes, so typically more susceptible to yeast infections. Pelvic floor muscles weaken and can lead to stress incontinence. So incontinence caused by, activity, that type of thing, that kind of dribbling effect. During menopause, the menstrual cycle will become irregular until it stops entirely. And then there's all those other side effects that we're all kind of familiar about rather, the hot flashes, night sweats. Sometimes you'll have complaints of painful intercourse, maybe even some abrasions could be reported, mood changes, sleep difficulties. So it's not, exactly a fun situation. So these symptoms can be reduced by replacing hormones, however, and we'll talk about that here in a little bit, whether that's always done or not. This is from your book on page 555. I would go ahead and look over this and just kind of have a good idea of what you would expect to see in that menopausal female. So for estrogens, if we choose to administer estrogen as a hormone replacement therapy for menopausal women, what it can do is reverse the symptoms of menopause, that flushing and sweating. It can help treat that atrophic vaginitis, that dryness that occurs due to the loss of estrogen, where they might have burning, itching, maybe a little bleeding. Like I said, they could have some abrasion there just because of the dryness with intercourse. Treatment for osteoporosis, because remember, estrogen helps keep those bones maintenance and strong. So it could be that that's the deciding factor on prescribing estrogen following menopause. Estrogen can also be given in men for treatment of advanced prostatic carcinoma. So in that andropause situation, estrogen can be a treatment for that specific type of cancer. And then in the event of certain types of breast cancers, which we talked about in the last chapter. But it is not without risk, because you think, oh, that sounds great. Why go through all of these, bad things associated with menopause when we can just replace the estrogen? But no, actually, there is some controversy on, weighing benefit versus risk, because with the administration of this estrogen, hopefully you remember number 1 from the last chapter, there is a big risk for cardiovascular issues, specifically the development of those clots like DVTs and PEs. It also can be linked to chronic heart disease. Transdermal delivery is being explored to reduce the use of oral products that have a lot higher effect on the cardiovascular system. But for right now, the physician should be evaluating that individual to determine if it's worth giving that estrogen to prevent those, signs and symptoms, or to allow them to transfer, through menopause naturally. Maybe they take calcium supplementations, that type of thing. These are our estrogens, so should look familiar. Okay, for estrogen administration, again, they should seem vaguely familiar to you. There's risk for headache, migraine, itching, dermatitis. We could have those skin pigment changes, nausea, vomiting, the cramping, the bloating. It could cause the resumption of bleeding, some breakthrough bleeding, withdrawal bleeding, spotting, changes in menstrual flow. Depends on where they are in the process of menopause. It also can lead to yeast infections, surgical erosions, and vaginitis. So again, need to make sure that we're giving it for the appropriate reasons. Excuse me. Local reaction, if we're giving estrogen injection, could be pain at the injection site, and then redness and irritation at the transdermal site, which by this point you guys should recognize those as common with any injection, common with any transdermal patch. So remember that there are some uh, associate some issues with the eyes as well, like when we're talking about estrogen in those contraceptive forms. So changing the corneal curvature, and then some people cannot tolerate wearing contact lenses. The biggies, though, are going to be those thromboembolisms and pulmonary embolisms. So development of DVT, development of PE. We might see some weight gain or loss as it results, or as it relates to weight fluctuation and the edema that can occur. Okay, you can look over these interactions. The herbal consideration from this chapter was black cohosh, which people have been using to manage symptoms of menopause for years and years and years. It's typically regarded as safe if used when directed, as directed. It's a member of the buttercup family, like the flowers buttercup. The tea is not considered effective as other forms, so it should not be boiled as a tea. So most of the time it is used in just an oral form. Your book touches on the SERM, or selective estrogen receptor modulators. It's kind of interesting. We'll just take a brief look at it. So they tried to make super estrogen essentially to work on estrogen's receptor sites. And the original drug that was created, the clomiphene, oh, I'm so sorry, is still used today to stimulate ovulation. I think I'm talking so much I'm losing oxygen to my brain. This original drug was used to stimulate ovulation and is still used today for people that are getting help with fertility, so to increase fertility and attempt to have a child. Later attempts, as they continue to develop these SERM contraceptives, it actually led to the discovery of tamoxifen, which is a potent cancer agent. So one of the most commonly used breast cancer chemotherapy agents. So that's pretty interesting. They didn't really get what they thought they were getting. So they tried it again, and they made another cancer-fighting agent in raloxifene. So it failed at treating breast cancer like they wanted, but it actually ended up being a great medication for treating postmental osteoporosis. So, that's why it's important that we have these people that develop these drugs, and they do these drug trials, and that's why it takes so long before they hit the market. Look at these lifespan considerations and other things. That those are oftentimes test questions, good, important information that the book is kind of highlighting for you. So here are our SERM medications. These are not given unless you work in a really special area like a fertility clinic, something like that. They can be used to treat things, like osteoporosis. They can be used to treat postmenopausal symptoms, but there's just other things out there that work better. They can either potentiate or block estrogen, just depending on what the need is. So again, that's why tamoxifen works so well as a breast cancer agent, because it can block the estrogen that is feeding that tumor. Like we talked about, those ones that just grow and feed off of estrogen levels. So, these are some of the things that it can treat. There is an increased risk of DVT, stroke, or MI in people that use these medications. So if there are any signs and symptoms, it needs to be discontinued immediately. Read through the adverse reactions, which closely resemble estrogens themselves, as well as some other things. One thing I do want to highlight and want you to know, I've bolded the SERM medication, raloxifene, should be stopped 72 hours prior to any procedure that would require bed rest. So this is the medication that's used to treat postmenopausal osteoporosis. So if this person is scheduled for, some sort of orthopedic surgery or something, maybe they'll be bedridden for even a couple of days, they have to stop taking this medication 72 hours ahead of time. So it's it has to do with the development of severe, profound hyper or hypocalcemia as it, is either moving in or out of the bones. So definitely want you to cue into that because you could be working in an area where you're seeing surgical patients. Okay, so we're moving on to the urinary system. So there are several times when we talk about aging and we say that, it's not normal or it's not a normal part of aging for this, to happen. But with our urinary system, it is especially susceptible to age, and there are expected changes that occur, and it's not considered dysfunction. Um, but again, just the process of aging. So the kidney changes in size, and the blood flow is decreased by almost 50%. So reduced size and reduced blood flow is going to be reduced processing of metabolites and waste products out of our urine. So that's why the elderly are so much more susceptible to medications, and why we want to make sure, especially if anybody has any kind of, um, kidney issue, that we don't end up in a nephrotoxic situation. So filtration decreases and urine becomes more dilute. So basically what that's saying is we don't clear waste products as well. So it's more just water coming out versus, being good at clearing waste. Urinary bladder diminishes in strength, flexibility, and capacity. So that could lead to frequent urination and urinating at night without any other dysfunction. So just simply by changes, related to aging. Now, there could be other things that you can't overlook. So always know what their baseline is. Maybe, they have an issue with frequent urination, but it's, to a much greater degree because they have a UTI. Or maybe they do get up and pee once in the night, but here lately they've been getting up and peeing 2, 3, 4 times a night. So know the baseline for that individual because it could be hiding, what we attribute to age could be hiding something else that's going on. The urethra shortens, which lends itself to increased incidence of UTI, especially in females. Remember that. There is a decrease in muscle tone and sphincter activity, so that leads to that stress incontinence that we were talking about. There's also a decreased perception that they've got to go. So, the older individual might realize that they have to urinate suddenly, and then it's like, oh, I got to get to the bathroom. I got to go because the bladder is now completely full and they need to empty. Overactive bladder syndrome can occur at lots of different ages, middle ages on up, but is significantly greater in the older population. And we'll talk about that and antispasmodics. And then we might see that enlarged prostate or that BPH, and it can contribute to hesitancy or that inability to start peeing right away. That's where it's helpful to do things like run water and those types of things. Give some privacy if they have a shy bladder, as they say. There might be urge incontinence and increased incidence of UTI as they retain that urine and it grows bacteria. They might have UTIs. Okay, the first thing that we're going to talk about is the antispasmodics. So the cholinergic blocking drugs inhibit bladder contractions and delay the urge to void. We'll talk about anticholinergics or cholinergic blocking drugs other times because they treat other types of things, but they kind of, work by drying things out. So if you have somebody that has an overactive bladder, that's how it reduces the need to urinate. They specifically, the mechanism of action is they block that neurotransmitter acetylcholine or ACH, and they prevent that spasm that uh, you know wrenches the bladder, clamps down on the bladder, and makes that person feel like they've got to go, and that's attached to the parasympathetic nervous response. So taking these types of medications can relieve symptoms of dysuria or uncomfortable urination, of urgency, of nocturia going at night. That's pain and frequency related with overactive bladder syndrome, and then the urge incontinence that can occur. Um, Mirabegrin or Mirbetriq is, and this little guy here, I put him on here. If you remember seeing the commercials, he's always leading the lady around like she's trying to watch the movie, and he's like, "Come on, we gotta go." So that's what we're talking about here. Those types of meds. So this one specifically works. It's a beta adrenergic blocker that relaxes smooth muscle. So it doesn't work quite like the cholinergic blocking medications in this group. But what you do need to know about a beta adrenergic blocker is it's like a type of cardiac med, essentially. But because of the way that it's designed and where it works, it has an effect on the bladder that relaxes those muscles and stops the spasm. It has a very, very low impact on the system as a whole, but being a beta adrenergic blocker, it can lower the blood pressure a little bit and that kind of thing. So you always need to cue in and know that on a medication like this, if they're also taking something for hypertension or specifically a beta blocker, then that could have a more profound effect in lowering the pulse, specifically, and also the blood pressure. Um, these medications can also be used to treat bladder instability that's caused by neurogenic bladder. So that can be caused by different types of spinal cord injuries. We'll go into that at the beginning of next semester when we talk about the neurologic system. But the bladder incontinence can be caused by damage at certain levels within the spinal cord, and these medications can help with those bladder spasms as well. So these are our anti-spasmodic drugs here. So remember, with that cholinergic effect of these type of medications, think that hot and dry. So I include this little meme here because this helps me remember about better than anything. Definitely associated with dry mouth, constipation, and urinary hesitancy. So they might actually end up with urinary retention and UTI and other issues like that from these type of medications. They may not have the urgency and the frequency, but we could give them a whole nother set of problems with these. So the individual might complain of feeling hot, flushed, dry, always very thirsty, dry mouth. It causes some visual changes, not so much these types of antispasmodics, but anticholinergics as a whole. They might appear flushed or red, as I already mentioned. And some anticholinergics are associated with confusion. There could be side effects of nausea and vomiting, vertigo, headache, those types of things. But what I really want you to know is that dry mouth, the constipation, of course, related again to that dryness, that lack of fluid in the makeup of the stool, and then urinary hesitancy versus the frequency. So if they experience any of these things, they need to talk to the doctor about it. It's not something dangerous enough that we're necessarily going to stop taking the medication, but we've got to figure out a way for symptom management. So, drinking 16 gallons of water is probably not going to be the best thing for this person to do. We're trying to slow down an overactive bladder. So remember those things that we can do for dry mouth. We can do, what can we do for constipation? And then we want to make sure that we're very careful, that we're watching, make sure they don't develop signs and symptoms of UTI. Okay, so these are going to be contraindicated in people with a hypersensitivity and with glaucoma, and that's because of those visual changes that these sometimes cause. They can actually induce a glaucoma-like visual change. So anybody in glaucoma, this medication could make it worse. We're going to use it cautiously, and anybody that has BPH, we don't want to give them this. It's going to cause them to retain urine worse than they already do. If they have urinary retention for any other reason, we're not going to give it. Hyperthyroidism as it relates to, being hot, dry, those types of things are an issue with that endocrine disorder, hepatic or renal disease, and then hypertension. Because if we're retaining fluid in other areas, we don't want to increase the hypertension. We're only going to use these in pregnancy if the benefit to the mother outweighs the risk to the fetus because they have been associated with some issues. You can look over these interactions for these medications. So BPH, just a quick A&P, and then I guess maybe a little pet peeve of mine. So the prostate gland is illustrated there by that big white circular thing. And as you can see, it kind of circles everything. It goes around the urethra, around the ejaculatory duct from the seminal vesicle. And so it's really poor placement. It's just kind of right there around all of those important exit points. So as that prostate grows with things like benign prostatic hypertrophy or prostate cancer, and BPH is not cancer, as it says, benign prostatic hypertrophy. So it's growing, but it's not a cancerous issue. Prostate cancer would be growing because of tumor production. So for BPH specifically, this prostate is just growing, 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 and what it's going to do then is compress. So it's shutting off basically the highways or the tracks to release urine and to release semen. So that can be an issue. Early prostate cancer may not have signs or symptoms. So when they have issues, come in and say, hey, I'm having trouble going, I don't pee as much as I used to, there's some blood or whatever, they need to rule out cancer before they can make a diagnosis and treatment of BPH, because we don't want to mistake something for what it's not. So the other thing is, and it's Missouri. Sometimes people say funny things. I know I can't talk sometimes, but I do have a pet peeve on prostate, that you make sure that you say prostate. Lots of people say prostrate, which means laying on your face. That guy's laying prostrate, but we're talking about the prostate. Okay, so drugs for the treatment of BPH. There's a lot to know on this particular slide. Before I go into this, I missed something that I wanted to share with you guys. So I want you to go to page 560 and do look up the herbal consideration on saw palmetto. It's not on your slide. You're still responsible for it. It's actually a pretty widely accepted treatment for BPH. So of the herbs, this one is commonly prescribed even by physicians. So it's not to be given as a tea. It doesn't translate well. It gets lost as it's brewed. So after taking saw palmetto, a lot of times there's improvement in 1 to 3 months after starting taking it. And then the physician will typically tell the patient to take it for about 6 months and then reevaluate and see if it has caused any reduction in the size of the prostate. So you are responsible for that information. So make sure that you get it included in your study. Okay, so page 560. So as far as actual drugs that we have prescription wise for the treatment of BPH, and again, we need to make sure that anybody that starts treatment has ruled out cancer. So it's not like, oh, grandpa's having trouble peeing, it's probably his prostate, like go get you some saw palmetto. No, we need to make sure that we're treating the right thing. So it's definitely monitored. We use medications, and there's invasive procedures that may be needed if we can't control it with medication. So that would be like a prostatectomy, like going in and removing a portion of the prostate, or there's another procedure that's less invasive, but it's still kind of a big deal, which is a TURP, which is a transurethral prosthetic resection. I mean, basically the same thing, but again, a little less invasive. We're going to focus in on the meds, though, at this point. So it's kind of broken down into a couple of things. We've got our alpha adrenergic blockers. So the big one there is temocillin, which is Flomax. And Flomax basically describes what it does. It acts on the smooth muscles of the prostate and bladder neck, and it allows increased urine flow. Star, though, it doesn't shrink the prostate itself. It is uroselective, so it increases urine flow without having a big effect on the vascular system. So that's great. It makes it a very popular drug for the treatment of BPH. All right, so the next group that treats BPH then is the androgen hormone inhibitors, or AHI. So the big one there is finasteride, and that's Proscar. Okay, so this one actually shrinks the prostate. So if somebody has a very enlarged prostate and we're concerned they might have to have a TURP or a prostatectomy, they're going to be put on finasteride first to see if we can shrink it, unless it's an emergent thing and they've got to get it done now. But they'll give this over some time and see if it doesn't do something. So it has a lot more side effects. It's declining in use because there is almost 100% guarantee that it's going to cause erectile dysfunction. It does decrease libido, blocks the hormone that stimulates the prostate's overgrowth, so we do get shrinkage. There is actually a combination drug right now being studied. It's got both the alpha adrenergic blocker and the AHI. It's called Jalin. Maybe it can give us some of the benefits of both of these: increase the urine flow and shrink the prostate. So you are responsible for all the information on this slide, and I would know how each of these work. As a side note, finasteride is also used for treatment of male pattern baldness. Instead of called Proscar, it's called Propecia, so you might have heard of that medication. It's finasteride as well. It also treats hirsutism in women, which is usually a genetic type issue in which women have developed very masculine characteristics. Okay, so these are our alpha adrenergic blockers, and then the AHIs. I would say your tamsuline and your finasteride, the Flomax and Proscar, are the ones that you're going to see most commonly. Doxazocin or Cardura is a cardiac med. It's for treatment of hypertension, but also can be used for the treatment of BPH. Okay, adverse reactions with the BPH medications. So if they're on one of the alpha adrenergic blockers, I'll say it again, I've already mentioned before, weight gain, fatigue could be issues, but again, there could be some mild cardiac effect just alone, so it can cause some orthostatic hypotension, because remember, I've said that's a cardiac med. But then to get ahead of ourselves a little bit, the beta blockers are cardiac medications. They're the ones that end in OLOL, so OLOL. So that's like our metoprolol and things like that. What those do is they lower the pulse and they lower the blood pressure. So if somebody's getting an alpha adrenergic blocker for the treatment of BPH, and then they're prescribed metoprolol, which is a beta blocker, for their cardiac issue, you could see a double whammy occurring there. So you have to be careful with the concurrent administration of those two. The one thing that you're going to check is going to be the blood pressure and the pulse. So the two things, my apologies, that you're going to check, the biggies there with the administration of that medication, blood pressure and pulse. And if they're on any other cardiac med, you're going to be all the more diligent. For the AHIs, we know that those have a high incidence of impotence, decreased libido, so you're going to have to talk to people about that. Please do not assume that just because somebody's 70 years old, they're not participating in sexual activity any longer. We've talked about this before, and you've got to be open, ask those questions, open-ended questions, and make that individual feel comfortable in speaking about those types of concerns. Durasteride might pass in the blood, so men taking that one and up to 6 months after discontinuing need to not donate blood. It could be potentially transfused to a pregnant woman, and it causes birth defects. So we need to make sure that they know with that medication that they cannot donate blood, and for 6 months after they stop taking it. One thing. So these are not, it says even though not prescribed to women, these can be prescribed to women, because remember, they treat hirsutism, which is the male characteristics seen in a female. So again, usually a genetic cause, but we can give these medications to kind of stop the presentations of those. So this is very, very rare. I wanted to clarify that because it's inaccurate that it would never be prescribed to women. That's the one exception. Okay, you can look over these drug interactions. Okay, so we're going to move on to drugs for erectile dysfunction. So again, these do not treat BPH, but having BPH and then the treatments for BPH, like those AHIs, can cause erectile dysfunction. So commonly associated. Erectile dysfunction is not an aging issue. 90% of it can be attributed to a medical condition such as like BPH. 10% of cases might be a psychological condition. So, literally in their head. So again, don't assume that things are just not working because they're old. That's not fair, and it's not appropriate. So while there are changes that occur with the urinary system and enlarging prostate and those type of thing, getting an erection is not one of those things that should be a problem with aging. And we might see a decline in libido and that kind of thing, but that's a very individualized thing. Sexual stimulation causes a series of steps, blah, 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 and it produces an erection by extending the corpus cavernosum because it's engorged with blood. So you do have to understand how that's working, because we could have cardiac issues, we could have a blockage issue like BPH. So, know how that occurs. These medications, the phosphodiesterase type 5 inhibitors, they're all oral drugs that facilitate that enzyme that allows that blood flow to engorge the penis, causing the erection. So Cialis, tadalafil is the only drug that is approved for daily use. Otherwise, they just take the pill whenever they are planning sexual activity. Cialis has another benefit in that it treats urinary difficulties related to an enlarged prostate. So it is a great medication for people that have BPH to address not only the sexual dysfunction as well as the urinary difficulty. So these are our impotence agents, the PD5Es. It's a lot easier to say. We've heard these before: Viagra, Cialis, those type of things, Levitra. The most common adverse reaction is headache, flushing, because what are we doing? We're increasing blood flow. GI upset and nausea can occur. Runny nose and congestion can occur because of that increased fluid, essentially. So drugs for erectile dysfunction should not be taken by men who use nitrates. Nitrates are prescribed for treatment of angina, chest pain, that type of thing. They can have um, a dangerous drop in blood pressure. Their blood pressure can become dangerously low if they take these two medications together. So it could be life threatening. It's a big deal to educate. Because these drugs affect the smooth muscles, patients that have any cardiac issues, taking drugs to lower blood pressure, any of that should talk to their primary healthcare provider before using the drug. The PCP should make sure that they're healthy is healthy enough for sexual activity. Medical attention should be sought for erections lasting more than 4 hours. This is called priapism. People kind of laugh like, oh my gosh, an erection for 4 hours, ha ha ha, you have to go to the hospital, that kind of thing. It's actually really serious. What it does is it essentially causes compartment syndrome of the penis. So if you remember when we talked about that, it just kind of blocks that blood flow. So you can see there, it's a really nasty thing. It causes ischemia and necrosis of that tissue of the penis, usually starting at the head. And so they've got to go in and essentially perform a fasciotomy. So, people are embarrassed about this, but it could end up in a really bad situation if they don't seek medical help when they need it. These are possible interactions that can occur with using erectile dysfunction medications. We'll talk a little bit more about hormones for cancer treatment. Touched on it in the last chapter, but these are primarily used in advanced disease. Some tumors have receptor sites for specific hormones. So remember, I said some hormones, if you block them, then they're no longer feeding the tumor. In some cases, these hormones can kill cancer cells. So if you're giving like the anti-hormone, it can actually destroy the cell. It just depends on the cancer, and it gets very involved on what works on what type of cancer, and can you block the hormone that's feeding it? Should you give the anti-hormone? All those different things is definitely very interesting, and we'll talk about it a little bit more when we talk about oncology. But it's a pretty difficult process figuring out how all the different types of cancers work. So a lot of times these assume an adjuvant or a palliative role, typically not curative. They're usually on some other type of chemo agent or radiation. So we don't give hormones only to treat cancer, obviously, but it can stop growth. It can, in some cases, kill or shrink, but it's usually given with something else, obviously, to fight that. These are hormone therapies for breast and prostate cancer. So it involves some of our steroid inhibitors, hormone antagonists, our blockers. Remember, our hormone releasing analogs are going to be replacing those natural hormones that are missing. The anti-androgens then are shutting down those androgen hormones. And then we've got our estrogens, of course, that are treating prostate cancer. It's like the anti-hormone coming to the rescue. So male cancers like prostate cancer typically feed on male hormones. Metastatic breast cancer feeds on female hormones, and that's in men and women. So it's just depends on what we're suppressing and what we're giving in that balance. These are some more hormones. Again, it's pretty vast depending on what we need to accomplish for that particular type of cancer. So always with any of these medications, or generally speaking now, complete a baseline assessment. You need to do a complete patient health history. You need to ask about a menstrual history. When did menarche begin? Or the first period? What's the normal pattern? Do they believe they've started in menopause yet? How many months since their last period? Do they have a history of BPH? Have we ruled out cancer? Do they have symptoms of an overactive bladder? that we talked about on the slide. Are they incontinent ever? Stress incontinence, urge incontinence. Do they have a history of clots? Do they smoke? Because remember, smoking doubles the risk of clot development in somebody taking an estrogen. Do they have a history of liver disease? Because we know that the estrogens and androgens are especially, the androgens specifically, are especially associated with liver cancers, liver cysts, and different things like that, and take the person's vital signs and weigh them so that we know what the baseline is moving forward. For medications that might affect the blood pressure, like the AHIs, you need to make sure that you monitor the blood pressure through the course of the therapy, and you're always paying attention if they're taking any other cardiac meds. And I'm sorry, I said AHIs, I mean the antiadrenergics. For evaluation, you want to make sure that the therapeutic effect is achieved, and that's pretty broad over the things that we just talked about. But we're looking for the urinary or reproductive symptom to be relieved. Adverse reactions need to be identified, reported, and dealt with. We need to make sure we're always teaching about these things. Patient needs to be free of pain. They need to feel like they can express their feelings, their concerns about body image, their concerns about sexual dysfunction, all of those different types of things. Happy studying.